everyone. This is Sierra Hatfield, Policy Analyst at the Council of State Governments headquarters here in Lexington, Kentucky. I staff the Interventions to Save Lives Subcommittee of CSG's Healthy States National Task Force. One of the policy areas the subcommittee has identified is disease and management systems, with a special interest on their relation to substance use disorders, or SUDs. One of the practices we've identified in the research as a potential best practice for states to consider is the idea of needle or syringe exchanges. So I'm talking today with Jose Benitez, Executive Director of Prevention Point Philadelphia, who is here to talk to us about Prevention Point, what it is, what it does, and how it saves lives. So Jose, how about we start with some background of Prevention Point?
Sure. So thank you, and good morning, everyone. Thank you so much for the invitation. Prevention Point is one of the largest harm reduction organizations in the country at this particular point. It is founded on harm reduction principles, which have really begun to sort of expand to areas like in public health. And so what we've become is really a public health organization providing a multitude of services, right? So our history comes from our syringe services programs from about 28 years ago now. We've been operating syringe services in Philadelphia for about 28 years that were sanctioned by the city of Philadelphia and actually paid for by the city of Philadelphia as a starting point. And what we then began to do was to sort of continually ask and communicate to our participants what it is that they need in terms of additional services, because we quickly realized that just becoming a syringe exchange service, while that's a principle and it's a valued intervention in itself, that a lot of the folks that were coming through that intervention were asking us for other additional services. And so it prompted us to grow. And one of the ways that we grew, one of the many ways that we grew is we began to sort of provide free medical mobile services to people who are in substance use disorder, people with who just community folks who can come out and needed or maybe uninsured can also access all of the services that we offer. So we grew. We also then grew into having office-based clinics. So we have an HIV clinic that runs out of the office. We have a medically assisted treatment clinic where we're prescribing Suboxone and we're prescribing naltrexone. We do that both office-based and out of our mobile trucks at this particular point. So we're actually doing mobile medically assisted treatment, which is really exciting for us. We have a primary care clinic that runs. We also have hepatitis C treatment that we provide to folks. We have a PrEP clinic, so we're providing Truvada to those folks who are coming in through the syringe exchange program. We opened up about 4 years ago a homeless shelter that's a low barrier homeless shelter that specializes in people with substance use disorder. We have 2 of those, 40 beds apiece, so 80 folks live with us. We have what we call an engagement center, which is a drop-in center, basically, where people, it's sort of like no pressure. People can come in, get out of the elements of the day, have a cup of coffee, and then there's staff to help engage. If someone wants any of the services that I just listed, they can sort of interact with the drop-in center to get that. We collect mail for the homeless. We have over 1,100 people that get mail from us at Prevention Point. And we provide meals. So we run a soup kitchen with meals pretty much every day of the week at this particular point. And we have mobile bathrooms that are located throughout the community in the Kensington area where we sort of operate. It's sort of in our city, the epicenter for the substance use disorder. Everything that's happening around drug use happens within the Kensington area. And so, all of those programs sort of add up to what Prevention Point has become in the last 12 years or so. There's been a major expansion in what we've been doing. So that's sort of the brief history of it. And the services, a quick summary of the services that we're providing.
So it sounds like Prevention Point is a lot more holistic than people maybe at first led to believe, because when I had learned about it, I had only heard about the kind of needle exchange aspect. So kind of with that in mind, what does the community kind of say about having all of these services?
So look, community reaction is always going to be mixed. What I will tell you is that overwhelmingly we have been accepted by the community, but that's due to the fact that we have tried to really become good neighbors to the people to the surrounding community, basically, right? So there's a couple of things that happen. We quickly learned that, for example, in our syringe exchange program, that what we really needed to do was also provide other health materials to people who may not be injecting drugs, right? So people can come to the van, for example, and get safer sex kits, condoms. Sometimes people need extra wound care because they're taking care of a family member. And so those are the kinds of things that we provide to people. Sometimes people come and they'll give us, because they're diabetics, they'll give us used syringes so that we can dispose of those for them, right? We do community cleanups on a regular basis. So we're walking around cleaning up any syringes that might be on the ground, but also participating in the neighborhood cleanups that happen. So those are all, excuse me, those are all methods for us to sort of become good neighbors. And any of the services that Prevention Point offers, it offers to the community at large, regardless of whether you have insurance or not. And I think those are, that overwhelmingly gets us, some support in the community. Now, the flip side of that, right, is the fact that syringe services, even though they're really, really successful, excuse me, and let me give you the elevator speech that I normally give to the politicians, right? If you look at Philadelphia back in 1991, in the midst of the AIDS crisis and the height of the AIDS crisis, about half of the new cases in Philadelphia, half of the new HIV cases were coming from people who shared syringes. Back in 1991, about half. When you introduce Prevention Point's intervention, the syringe exchange program, you fast forward it to last year, that 50% went down to 5%, right? So we averted all of those HIV infections. And one of the things that I like to say about syringe services programs is that if you look at this, right, we're very proud. We just got a research article published from George Washington University about Prevention Point and the Baltimore Syringe Exchange Program. And what they found was, with all of these averted HIV infections, we typically save the city about $240 million a year in averted HIV infections, right? So it's really clear that syringe services programs really help public policy and save taxpayer dollars. So those are, and basically saves lives. So those, it's a mixed bag. I think we're sort of more accepted because we do a lot of community work, and we also do work with law enforcement. I meet regularly with our police captains in our district to make sure that we're having ongoing conversations about where we're operating, how we're operating, so nothing is a mystery to our law enforcement partners.
Okay, so if the research really supports needle exchanges, in your opinion or in your experience, are needle exchanges enough to kind of quote unquote fix the SUD problem?
So I don't think there's one thing, there's one tool or one sort of intervention that's going to work to fix the problem. I think that syringe exchange services should be viewed as one tool in a toolbox that it contains a lot of other interventions, right? So let me give you examples of what I think, and how I think syringe services should be complemented, right? First of all, look, syringe services programs are really good at accessing and reaching people who typically are quote unquote hard to reach, right? They're folks that are actively injecting, who may not be, as the street vernacular goes, they're off the grid, right? So they may not be accessing other services regularly. So that's one place that we should sort of see syringe services as a outreach tool. Second, I think that it is a good place to be able to begin education in the communities that are very hard to reach. So if you look at the kind of education that we would need to pass on, like don't share needles, right? If you ask any of our guys on our syringe exchange line, what's the golden rule? They all are going to tell you, don't share needles, right? Because of the HIV infection, the risk of the HIV infection. So, having the opportunity to provide educational services and education about other programs and other interventions is one of the key components of having a good syringe services program. The second thing, though, it shouldn't operate in a vacuum. I mean, that in itself is great, but one of the things that we also try to do is make sure that we're also challenging all of the other systems in our city, right? So for example, the treatment system. So there's a direct link between admissions to the treatment system through the syringe services program. So for example, we can get someone into a treatment slot if they need to quickly. And that's the key, treatment on demand. So that's another tool that, as we begin thinking about how syringe services programs fit into a larger system, that's one of the key ways that it could connect, making sure that they have direct connection to treatment slots that are available. And the same thing holds true in housing services, because you want to make sure that, like, if someone comes in and they're homeless and they request a place to stay, that there is an ability for somebody to get into an emergency shelter bed as soon as they can, right? And lastly, I would say that if we're also thinking about how do people access healthcare, and that could be a relationship with a local emergency room, making sure that people can get into and access medical care as soon as they can, but also not just emergency rooms, clinics, doctors, all of the normal sort of healthcare access that gets provided to other folks, that we have some kind of expedited warm handoff strategy to hand people off to the various systems. So, to sum it up, syringe services programs really are the first step in us addressing the substance use disorder.
Okay, cool. What are some of the numbers associated with some of these programs? Like, how many people are actually taking advantage of these services? And if you have any kind of reports or research on, people that have really turned around based on the help you're providing?
Okay, that's a good question. I mean, look, I can tell you what our local numbers are, right? If you look at, I want to just take a step back in this question for a minute. If you look at the fact that we, 4 or 5 years ago, our syringe services program was providing services to about 4,000 unduplicated people a year, right? Then we had this resurgence of heroin use in the last 4 years. And we now serve 15,000 unduplicated Philadelphians in our syringe services program alone, just in that program, which translates into several 100,000 interactions with people when if you duplicate the numbers. So that's sort of the spectrum of it, right? But what we then began to do was we figured out that if we were going to sort of have a medically assisted treatment clinic, which is where we're prescribing Suboxone and naltrexone, we don't do methadone maintenance, but Suboxone and naltrexone in our office-based clinics, we also began to hear feedback from the folks, the clients that came in to get services, that they wanted to see whether they can access the service mobilely in our mobile vans. And so that we began to work with the DEA and figure out how do we do this so that we can provide Suboxone scripts and assess people on the street. So if you look at that one program, which is, introducing people in many cases, sometimes for the first time, but in other cases, for the fourth, fifth, a number of different times, when people have come into the treatment system and are able to access it almost immediately. And we have about 250 slots, and all of our slots are full. They are full all of the time. And so part of what we're doing now is trying to, we're expanding so that we can increase the number of slots that we have. So if you look at that, right, about a quarter of the folks that come in have been doing really, really well. We're working on getting that, and really well, meaning that they're on their medication and that they're, consistent with it. We've been measuring it for about a year or two now, and we're hoping to get that 25% rate a little higher at one point. But it's sort of a logistical, you have to sort of think a lot through the logistics of the kinds of programs, because we're learning how to also figure out how you can start at the van on the street and then gently have a warm handoff to coming into the office so that we could stabilize you a little bit more. So that's one area. The second area, though, is if you look at it in one of our programs, you look at our shelter program, we house about 80 people. Most people come in, it's a low barrier. And what we've done is we've introduced, again, medically assisted treatment into the shelter system. So people don't have to go anywhere. The doctor comes to them. we evaluate them. And there, when you look at it, we have a way better percentage rate. And I think it's at 67, 68% at this particular point, where people are actually stabilizing, doing well, and then are able to take next steps in housing, right? In either transitional housing, leading to long-term housing. And I think that that's something that we as an organization are really proud of, because what happens is we consistently are asking people, what do they need to help them move on to the next step. And I will say that, like, our prep clinic is the same way. There are a bunch of folks who are on treatment. They get it right there. They get the prescription right there. And then, the pharmacy will deliver. We figured out how to have a pharmacy deliver to folks, right? Just wait around for a few minutes and deliver the Truvada right to folks. So we're putting it in people's hands, and then we're monitoring them when they come back. So those are all kinds of ways, right, that we as an organization have really worked with participants to figure out how we help them succeed.
Okay, well, my next question was going to be kind of about those future wishes for the organization, but you kind of touched on that a little bit. It sounds like you guys want more direct outreach just to be bigger and better, because what you're doing currently is working. But is there anything else you'd like to say to maybe what Prevention Point has going on maybe for the future?
Yeah, I think, we have to, at one point, begin to talk about how we bring people back into the workforce, right? And that's something that when we talk to participants, right, we have a work development project at Prevention Point. We hire a lot of our participants. So I would say about half the staff at this particular point are people that are recovering or have been in one of our programs. And so, figuring out ways that we can support people to come in and go get back into the work environment is really, really important. And I think that, because it's a struggle, right? When you have someone who may have been arrested several times because of their drug use, right? Getting back to work is somewhat difficult. And so designing specialized programs that target this population to get them back to work is something that I think is really, really needed. So that's something that we're going to focus on in the next year or so.
Right, and those are kind of the uncomfortable conversations that states should probably have. You have this population who is struggling, seeking help, getting treatment, but then what's the next step?
Agreed. And I think that, all of these, right, conversations like this, the one around syringe exchange and the one around mobile medically assisted treatment, and this conversation where we are now in terms of getting folks back to work, are very uncomfortable conversations, right? They're not traditional. And so, but what we can say is that they are somewhat successful, and we should be trying and figuring out how to have the uncomfortable conversations in order to sort of improve some of the outcomes that we'd like to get to.
Right. Well, Jose, I just have one more question. It's kind of like a catch-all for any final thoughts. So the Interventions to Save Lives subcommittee is very focused on kind of two research priorities as we come across these state programs and these best practices that we try to evaluate them by. So the first priority is we want to look at savings, not just fiscal, but also in terms of human life and quality of life. And then the second priority is we want to find recommendations for all ages. So with either one or maybe both of those things in mind, is there anything else you'd like to say to the subcommittee as we continue the conversation about the best way to handle SUDs?
So sure, a couple of thoughts, right? So one piece of it is, let me just start with syringe services, syringe exchange services. One of the pieces that we figured out quickly, right, just out of necessity, is the fact that we needed to attach overdose prevention program to our syringe services program. So we give out a lot of Narcan in that program, right? You come to exchange, you get Narcan. That's just, you know, something that we practice on a regular basis. That in itself, right? So what we've done in our zip code, if you look at the zip code where Prevention Point, the office where we operate, our zip code actually had a 21% drop in the number of overdose deaths last year, even though citywide, the overdose deaths went up. But in the zip code where we were, it dropped, the overdose deaths dropped by 21%. So if you look at it, it's really solid evidence that having the programs that reach quote unquote difficult to reach folks and tacking onto them other kinds of services like training people to recognize overdoses, use Narcan, and then come back and get more Narcan, because these are the folks that are at highest risk. And it's while we should be continually supplying our law enforcement and first responders, we should also continuously supply Narcan to people who are highest risk of overdosing themselves. So that's one piece of it that I would encourage the committee to sort of look at. It saves a ton of money in terms of the human cost, you know, in terms of overdose deaths themselves, but it also saves a lot of money in terms of having first responders having to respond to every single overdose that happens all the time. It's just like for us, that became something that was seemingly impossible for us to sort of, you know, for the city to respond to. Second, I would say that, you know, I'll refer you again to the George Washington University study that talks about, you know, if we, I know that folks like to look at dollars and cents, and to really look at that George Washington University study that really talks about syringe services programs and how they save municipalities some big money because of the averted HIV and some hepatitis C infections. And so there's, you know, definitely some tax dollars that could be recouped with these kinds of approaches. In terms of the different ages, you know, we right now we're restricted. So we deal with folks who are 18 years and older. But there are, you know, prevention programs that are out there, I think, for folks that, and specialized programs that are in the treatment system for people who are under 18, that really, for the most part, like even in a city like ours, which has a lot of robust treatment, you don't hear about much. And I think that that's something that is lacking, having more public awareness about what's out there for people, and you know, making sure that people have access to all of those treatment options that may be out there. So those are my thoughts.
Well, it sounds good to me. Thank you so much for agreeing to come on today and sharing some of your experience with Prevention Point, telling us a little bit about the history, where it is now, where it's going, and really advocating for, you know, not just a needle exchange program, but something that's a little more holistic that treats the whole person and gets them back into the workforce. I think that was an amazing point that you made. So I think that's all that I have for you. And again, just thank you so much.